Okay, let's get started here as last couple people are drifted in. Thank you for coming to Grand Rounds, our last Grand Rounds for summer. Thank you very much for your attendance. So we've got a really interesting talk. As the health center develops, as we grow, we bring in new treatments, new testing, and procalcitonin is one of the new testing that's our lab services and pediatrics has become champion to bring into the hospital. So we want to have this information session and bring in some experts both procalcitonin. So I'm going to introduce the speaker, who's Dr. Michael Broyles, and he's the Director of Medical Affairs at Biomarkers at Thermo Fisher Scientific. The PhD in pharmacy, who is specializing in IV and geriatrics and has more than 30 years experience as a hospital pharmacy and laboratory director providing patients and current concepts in the clinical use of drugs with a focus on antimicrobial stewardship. His current role is Director of Medical Affairs, Biomarkers for Thermo Fisher Scientific. Prior to joining Thermo Fisher, Mike had more than 25 years consulting for a large IHN as a pharmacy advisory chairman to develop and implement clinical initiatives. His goal is to provide the leading thought process in patient management and use technology to enhance the ability of clinicians to have the best options in patients' clinical status, decision support, and improving outcomes through better clinical care. So Dr. Broyles is going to come up and speak first, and Russ Price is going to come up from the lab perspective, just tell us the current state of the testing here at RVH. Before we get to bring Dr. Broyles to speak, on your desk you'll see a QR code. People who collect CME, so physicians, NPs, PAs, you can scan that and fill out a quick survey to get your CME credits emailed to you. So without any further ado, Dr. Broyles, welcome.
Okay. Let's get it. Well, great. Let's get started. Let's talk about PCT. This is my disclosures. I think most of that is covered. Just a little bit of background about me. I spent 30 years as the director of pharmacy lab. I still did patient care. Half my time was doing patient care because dealing with the C-suite, nobody can take 100% of the time. Okay, that was me. That was my mentality anyway. And so in that time, I was the second user of Procalcitonin in the United States. I've looked at more than 70,000 determinations. We did a lot of studies, advanced analytics, and things like that. So that's kind of where I'm going to come from. So as far as goals and objectives, I'd like to understand PCT. It makes no difference. It makes no sense to bring in a test if it doesn't offer something that you already have. Okay. And so what I want you to do is feel very comfortable about that. I want to be able to differentiate PCT from other biomarkers because there's others out there that we can look at, we can use. We're going to talk about its role in antimicrobial stewardship. Depending on time, I'm going to talk about some of the nuances, and then we're going to look at a few outcomes. I'm going to talk about PEDS. So I'm actually going to do the case studies are going to be adult-based, and then I'm going to talk a little bit about some of the indications in PEDS and those types of things. And so I think you guys all know this, but just to kind of set the stage is that we use more antibiotics than we need. And we do that because we're unsure. And we use that term so many times just to be sure. I can't tell you how many times that, I talk to my clinicians like, we probably don't need to go there. Like, yeah, but just to be sure. And that's what we do a lot of times. And so obviously there's many side effects. There's toxicities, there's C. diff. But resistance is one of the big things. And so one of the things that we continue to look at is that resistance. So it's estimated that deaths from antimicrobial resistance now are just over 1 million. Okay. It was estimated by the year 2050 that was going to be 10 million, which would make it the largest cause of death globally. Okay. Now, 3 weeks ago, the number was revised to 18.6 million. It was almost double, because we continue to overuse antimicrobials. And so obviously we need to do something a little better. But it's kind of silly, if you really think about it, to go to somebody and go, okay, you're taking care of patients, use for your antibiotics. I mean, you need tools to help you make better decisions. And that's where I'm going with this. And so kind of the key concept is if you just say, I want you to do better, but don't give someone the tools to do better, that's kind of ludicrous if you think about it. And so one of the things that I always want to point out is that microbiologic cure is always ahead of clinical cure and radiographic cure, because these things always lag behind. And so there's a lot of times we are treating people when that part's already done. All right. But we continue to do that because we're waiting to see how the patient looks. We're waiting to look at that chest film or whatever the case may be. And so with that in mind, there are some things that procalcitonin will do. Okay, number one, it can help you differentiate, is this infection that you're seeing, this inflammatory response, Is it viral or bacterial? Because it can do that. It's going to tell you on initial presentation, what is the severity of bacterial burden by the number. Talk about that. And then if you do the serial measurement, it's going to tell you, are my antibiotics working? And in many indications, when can you safely stop? Because in our minds, we always go, more is better. Okay, more is not better. More antibiotics is not safer. I'll show you the data behind that. So in the end, if you use procalcitonin, it will actually change the way you practice. It will make you change because at a point in time, where is my bacterial burden? Is it improved and when can I stop? So it makes you change your mentality and your thought process on that. And so if we look at the markers that are out there, these are a few. White count. I mean, if you got paid for your value, the white count is pretty bad. We can talk about ratios, we can talk about neutrophils and bands, but the bottom line, there's almost 600 drugs or diseases that affect the white count either up or down. It's a very poor performer. And the key is this part about specificity for bacterial infection. That's the key, okay? Notice how white count's affected by the inflammatory processes. C-reactive protein, very similar, slightly better, but its time to peak is 48 hours. How much can happen to a patient in 2 days? Think about it. And then I included lactate. I only included that because people think of PCT and they think of sepsis, but lactate has nothing to do with infection. It's marker confusion. We know that. And so the key then is this. If we look at other ones, we can talk about IL-1, IL-2, IL-6, 10, CD64, soluble trim. We can done the list. We know there's at least 380 of these that we've studied, but they do not have the ability to differentiate. Only recently have we had trail 910 that can tell us, is this viral? Okay, but then there's still that viral versus bacterial piece. This is the key. Procalcitonin is this piece right here. It's specificity to bacteria, okay? Now, procalcitonin has two parts that I want you to kind of think about. It has the part where you're thinking, do I need antibiotics? Because I'm doing this viral versus bacterial situation. And what's the initial severity? And the second piece is, how long do I treat? Okay, so when you look at these studies, people talk and they'll do things and they make assumptions. PCT is always about, do I start? How severe is it? And then how long do I treat? And that's where I want to go with this. And this is why. If you understand this, then you would totally understand PCT. So for you to make procalcitonin, so I said make, okay, that means it's not stored. For you to make procalcitonin, you have to have two things happen. You have to have bacteria affect this toll receptor. Without it, you cannot make PCT, okay? Doesn't matter if it's gram-positive, gram-negative, cell wall breakdown components, endotoxin, exotoxin, something bacteria affects the toll receptor in the presence of these cytokines, IL-1, IL-6, and tumor necrosis factor. You get those from any infection. You get those from a viral infection, bacterial infection. So the key then is that you must have bacteria to make PCT. All right, and we'll be very clear about that. The other piece is that process takes 3 to 6 hours. So it's very timely. So once bacteria activates the toll receptor, then you make PCT. It's measurable within plasma or the serum within 3 to 6 hours. Now here's the other piece. It's not affected by steroids. It's not affected by oncology. If they're neutropenic, leukopenic, it doesn't matter what drugs they are under other disease states, you will make PCT. Okay, it's reliable. Now here's the other thing. I said viral versus bacterial. So the first piece was in a pure viral infection, then pure viral PCT is not made. So the question would be why? Well, it's very simple. There's nothing activating the toll receptor. Okay, we know we have more than 13 toll receptors. This is just called the toll receptor. And the other piece is there's a negative feedback mechanism with interferon gamma, so that even if you get those IL-1, IL-6 tumor necrosis factor, you can't make PCT. So in a pure viral infection, you don't make PCT. Okay, very simple. Now here's the other question you're going to ask me. You go, well, Mike, okay, what happens if you have a mixed infection? I have a seasonal influenza and they come in with bacterial pneumonia. Will you make PCT? And the answer is yes. Anytime you have that toll receptor activated, it overrides everything else. So mixed infections, you make PCT. That's the pathophysiology. Okay, so does that make sense for everyone? It's pretty straightforward. So then, if you think about it, the amount of PCT you get is in direct proportion to bacterial burden. This is all common sense stuff. So if I have a very localized infection, I'm not affecting many toll receptors, I don't make much PCT. As that infection becomes systemic, I affect more and more and more toll receptors, so I make a lot of PCT. So that is that piece about the initial bacterial burden. Okay, that's telling you something about that. And the other piece is that PCT doesn't tell you where the infection is. You have toll receptors everywhere except in the heart. Okay, now the density of toll receptors can vary, but you will have toll receptors everywhere. So diagnostically, we have to figure out where that infection is. Okay, so then essentially we're going to say anything that 0.05 to 0.1 is normal. You always have some procalcitonin in the background. You will always have that. Most of the time we say in that 0.1 to 0.5, that's a localized infection, and these numbers get higher, then it becomes systemic. Most hospitals use 2 as a lower value. Some will use 10 as a critical value, and these numbers can get very high, like to 1,000. Okay, the higher the number, the greater the cause for concern, and then also prognostically can help you because failure of PCT to go down by 80% over 96 hours or 4 days. There's a 50% increase in likelihood of mortality that's demonstrated very clearly in the Moses trial. So a lot of information that you can glean from that. Okay, so now that's the pathophysiology. Now here's the kinetics. You got the second half. You can use PCT incredibly well. So I said rises in 3 to 6 hours. Okay, it peaks in basically 24 hours. Now it's biphasic, kind of 12 hours. But just say once you see bacteria, time to peak is 24 hours. Okay. So then you would expect then that if you have a bacterial infection and you don't treat it, what's going to happen to PCT? It's going to go, no. Okay. Its elimination half-life, the time for it to go down by half, if you've given the correct amount of correct antibiotics, is also 24 hours. Okay. And so based on that elimination half-life, then the best time to evaluate are my antibiotics working is 24 hours. So you can expect it to go down by half every 24 hours. And it does it very well most of the time. Okay, so now I'm going to hit pause for just 1 second. Okay, I'm going to finish the kinetics, but I want you to think about this. Okay, so if you look at your CAP patients, okay, CAP is estimated that 38 to 40% of your community-acquired pneumonia patients have a bacterial infection, right? But the guidelines say radiographically or confirmed CAP, suspected or confirmed CAP, we're going to give them 5 days. So that means you're treating 6 out of every 10 patients who come in with antibiotics and never needed them in the first place, and for 5 days. Does that make a lot of sense? Okay. Now, the same thing with COPD exacerbations, about 50-50. Okay. They're viral or environmental or it's bacterial. And even people who meet the sepsis screening criteria, it's about 40-60. 40% are later found that they don't actually have a bacterial infection, or 60% are confirmed. So just think about that. Now, with that in mind, the way I put that in there, I want you to think about this. So here is time 0. So here's the ED. All right. A patient comes in, say this value is 10. I've started antibiotics. 24 hours later, I repeat that PCT. And if it's gone down by about half, my antibiotics are working. It's very simple stuff. And I would expect it to go down by about half every 24 hours. All right. There are some situations where you have a protected location, or maybe it's not the ideal choice of antibiotics for PCT. It will be kind of flat where it'll go up in that first 24 hours. Doesn't happen very often, but I'm telling you everything, A to Z. And in that situation, generally, if you're patient, then it'll probably go down. Okay. Now, here's the other thing. What if I have a PCT that starts out somewhere and it goes up a whole bunch in 24 hours? It means my antibiotics are. I don't have to wait till that patient crashes. I guarantee you with 100% certainty, if you're at a PCT somewhere and it doubles, triples, quadruples, you need to change antibiotics. I ended up, the first 2 weeks we started using PCT, I had a patient who actually had a PCT and it came in, it was like 6. The next day it was 26. And my clinician said, I don't give a about that test. I look at the patient who just needs more time for antibiotics to work. The next day it was 96 and was on the vent. Do not wait. If that PCT goes up, it tells you a lot of useful information. So if that infection then is uncontrolled and you do make the appropriate change, then it's going to go down. And here's why I inserted that one slide. What if I have a normal PCT on admission and I have a second normal PCT at 24 hours? What does that mean? Did I ever have a bacterial infection in the first place? Exactly. It's telling us with over a 99% negative predictive value that you don't have this. So even if you started antibiotics, the patient's improving, maybe you have the opportunity not to continue on those patient populations. So then when's the best time to start? So these are directions that came from the FDA, and this is from some of the US guidelines. And what I'd like to just say is this. If PCT is 0.25 or less, this is kind of indicating I probably don't need antibiotics. If it's 0.26 or greater, that's my start point. And that's pretty much for any infection. Okay, very simple. 0.25, 0.26. Okay, that's a great point. So then let's think about this. Fixed durations. Is fixed durations very intelligent? And if you stop and think about this, this was actually done by Spielberg and colleagues back in 2016. And he looked at long-term courses, the old style, and he looked at new style, shorter durations. And you can see this is CAP, those common pneumonia, pilo, sick people, right? And so what you can see is 7 to 10 days, 3 to 5, 10 to 15, less than 8. And they did the short course and they looked at the outcomes in these patients, and guess what? What happened? Were the outcomes better or worse or the same? The outcomes were better or the same, okay? Which tells us right away then that we've been treating people way too long, okay? And so my question is, does it make sense to even treat for a fixed duration, okay? And so let me draw this point, okay? If this is the approved indications for use, if, and this is respiratory tract infection sepsis, this really can be applied to UTIs, to a lot of other things, okay? But if PCT has an absolute value of 0.25 or less in CAP, COPD, or acute bronchitis, or in sepsis, your ICU patients is an absolute value of 0.5 or less, or there's an 80% reduction from your maximal value, and that patient's improved clinically, then it is safe to stop. And that's where I'm going with that, because more is not better. And this is kind of one of the key takeaways. So here is some of the data. This is just a few trials that are out there. These are all randomized controlled trials. I can show you 3, 4, 5 times more of this on randomized controlled trials and real-world evidence hundreds, okay? What you see on the right is the percent reduction in antibiotic use. And in every situation, it was a safer. And this is in lower respiratory tract, it was in children and adults, sickest of the sick, and even in neonates, okay? So then the next question is, when this is the thing that's so hard is, it's like taking the blanket away from Linus. If you can go back to the Charlie Brown Peanuts, I don't know if that's, you guys remember that or not, but it was like, I have to have these antibiotics because it makes me feel warm, fuzzy, and comfortable, okay? So then the question is, and this was an 11 study meta-analysis done by Weirs, and they looked at the use of PCT and they said it basically less safe, as safe, or safer. So it was non-inferior or safer. The odds ratios in every situation were in favor of the use of a PCT guided algorithm. So in just a few slides, I showed you, you can actually use less PCT and it's actually safer, okay, than a standard of care that doesn't use PCT. So the question is, where can I use PCT in Canada? Where is it approved? Take your pick. It's everywhere. So this is in adults, in geriatrics, it's in surgery patients, it's in oncology patients, pediatrics, and even neonates, okay? So if you want to know where it can be used, take your pick, all right? That's pretty straightforward. I'm going to show you some case studies. These are not complicated. They're not meant to be difficult or anything. These are things that you would see day in and day out, okay? I'm not trying to impress you with anything, but it's the bulk of the types of patients that you'll see. And so I have AD, this is a community-acquired pneumonia, so I have chief complaint history, physical exam. So 55-year-old female presents to ED with cough, yellow sputum, fever, chills, asthma, hypertension, non-smoker. She's hypotensive. She's 39.2 as far as temp. She's tachy at 115. She's tachypnic at 25. Bronchi, and this is her chest tone. Okay, so you see her white count's 20. Okay, we got a little white count. Her lactate's 3.1. Okay, but her PCT is 3. Okay, do we have a bacterial infection that needs antibiotics? Absolutely. Okay, so here's what happens though. So she started on ceftriaxone, azithromycin, bronchodilators, albuterol, O2, fluids for suspected sepsis. And then basically the diagnosis was confirmed and she gets antibiotics for 3 days. And let me show you why. So is this something that you would do here? Is this a very common situation that you would see? I think probably the answer is yes. So PCT 3, all right, antibiotics are started. So when can I safely stop if she's improving? So to get that 20% calculation is you simply multiply whatever maximal value is times 0.2. So years ago, I actually presented information to the FDA and I got a call from one of the companies afterwards and they said, the FDA thinks the clinicians need this complicated formula where you have to put in three numbers to get the percent reduction. I'm like, you multiply it times 0.2. Okay, it's simple math. But anyway, so if you're not sure about this, so 3 times 0.2 would be 0.6. When PCT is less than 0.6, you can safely stop. All right. So in this situation, the antibiotics were discontinued. So she did have a bacterial pneumonia. Antibiotics were stopped. Now, let me ask the other question is, okay, if she were here or many hospitals throughout the US and Canada, how long would she get antibiotics? She probably would get them as long as she was there, or at least 5 days. But what happens when you discharge them home? You send home outpatient prescription work. I tell you, in the US, they do it all the time. And it's like, and understand that anything you take orally is harder on the gut than most of the things you take IV. And so there's definitely microbiome things. So anyway, she's discharged home. Very simple step. Now, this one is SD, 65-year-old female, COPD exacerbation secondary to CAP. So cough, wheezing, increasing shortness of breath, COPD goes stage 2, type 2 diabetic. Got anybody like that? Diabetic comes in? Yeah, every day. All right. So Tim, just under 39, white counts 14. Okay. Chest round said right over low infiltrate. I'm lucky if I ever had any of my radiologists actually give me this much information. You guys are probably the same, I would gather. Okay. Petra's their favorite plant, by the way. Okay. 4 liters nasal cannula, bronchodilators, ceftriaxone, zithromycin. But let me tell the rest of the story. PCT is 0.12. 0.25 or less. Do I need antibiotics? Probably not. She was influenza A positive. Oseltamivir was started, and she remained on antibiotics due to concern that this was a bacterial infection. So next day, PCT is 0.09. I have 2 negative PCTs, 2 PCTs less than 0.25, 0.26, or 0.25 or less. I now have a negative, 99% negative predictive value. She's improved because she's on 2 liters nasal cannula. Her tip's 38. And the stewardship team says, can we stop? Because this is probably not a bacterial infection. And so here's how this happened is antibiotics for 1 day. That's a lot better than 3 to 5 days. And then there's one thing that happened, and I included this case because of this reason. So when you first start discontinuing antibiotics, and if that patient is still in the hospital, what you may be tempted to do is repeat a PCP the next day so that you feel like it didn't go up because everybody thinks it's going to go up. I can tell you in over almost 7,000 patients in CAP, COPD, sepsis, UTI, that it would go up less than 1% of the time. And usually when that happens, it's another site of infection with another organism. And that we spent a lot of time looking at that. But in this case, the PCT was repeated the next day. Now I have 3 negative PCTs. I feel very comfortable in saying, good choice, no antibiotics. So in this case, she was discharged home on day 3. Okay. Now this is one of the reasons that you do serial measurements. Very, very important. This is 2 separate urinary tract infections, but the clinical presentation was almost identical. So I have JB and then I have LD. So down across everything, just almost identical. 4+ bacteria, leukocytes, race, all that stuff, right? So in the first situation, PCT is 4.3. So this is a lot of bacteria, right? Okay, definitely it's based on what we just looked at. Ceftriaxone, first situation, levofloxacin the next time, okay? And so what we actually have is, here's the levo, ceftriaxone. The next day, ceftriaxone goes down, my antibiotics are working. This situation, my antibiotics are not working. In fact, she decompensated and she went to the ICU. So at this point in time, early that morning, she was in the ICU. So at this point, the levofloxacin was replaced with the meropenem because there was concern that she had an eosinophil producing organism, which is fine, if that's what they wanted to do. And here's one of the things you can do, but don't do often. I don't want you guys running a lot of tests that you don't use because we don't sell anything. All I do is education. But notice it said day 1 a.m., day 1 p.m. If you have somebody who's critically ill and you change therapy, and you can get about 12 hours in before you can do the next PCT, it will generally flatten or go down. Why would I do that? Well, if I check it again and it's going down, I know I made the right choice, but if it's still going up, I made the wrong choice and I can change 12 hours sooner. Does that make sense? So what we actually saw was the PCT went down. So at the end of the day, when we go home, I'm like going, good, all right? And so you'll see then the next day, from 23 to 12, that's about a 50% reduction. Okay, now 23 times 0.2 is 0.46, 4.6. When I get to PCP at 3.9, I will stop. Now let me ask you this question. If you had somebody in the ICU and they had this type of infection, would you be tempted to treat them longer? Just to be sure. Yes. Okay. Do I need to? Not really. Okay. But, you know, we would be tempted to do at least 5 days. So, I mean, they're in the ICU, right? Super sick. This is telling us that you can safely stop. Okay. And here's the other thing that's very interesting. In heart failure patients, statistically, 1 in 5 heart failure patients who hit your door in the ED have a pneumonia that's coexisting. So it means 1 out of every 5. Now, here's the interesting thing. If you don't treat those patients, if you just treat the heart failure and you discharge them, and it's just this low smoldering type of pneumonia, their risk at 30 days mortality is 18% higher, and at 3 months it is 23%. Okay, so it's important to treat these patients. So you get these, they come in, and this is what we have. So increasing shortness of breath, some cough, cyanotic, no fever, chills, setting in the mid-80s, smiling, jugular sinus extension, previous heart failure, MI with 3 stents, severe COVID requiring ICU admission, type 2, and he's morbidly obese. Okay, differential diagnosis is heart failure versus heart failure with full infection. All right. So when we look over here, his temps 37.7, respiratory rate's 28. He's normal intensive, heart rate's 86. Against 12.8. Okay, and his neutrophils are 82. It's like, well, my skirt's not blown up yet. I mean, it doesn't impress me, right? It doesn't look that sick. So lactate's 3.2 and his BNP, NT pro is 3 times normal, but his PCT is 1.45. What do I have going on here? I have, yeah, exactly. A bacterial infection needs to be treated. This last time in the ED, it was 86, and chest films said pulmonary edema, cardiomegaly, pleural effusion. So essentially the same thing. You start antibiotics, you still do all the heart failure stuff you're going to do, but 1.45 times 0.2 is 0.28. After day 3, I can safely stop. Okay, very straightforward stuff. So the other piece is that procalcitonin in pediatrics, everything about procalcitonin is exactly the same after 72 hours as it is in adults. So there's nothing to learn in that time. In the first 72 hours of life, PCT is elevated, and there's actually a nomogram that you go to, and it will tell you, say, at 24 hours what to expect, at 48 hours what to expect. And that's because basically a child comes from a sterile environment. They come out in the world, and what are they bombarded with? Bacteria. It all activates the toll receptors. And so this is where they're at. You actually can use that to treat neonates. All right. So what about pediatrics? So there's a lot of information. I know this is where you guys are at here. So this is position statement. Again, this is with the Canadian Pediatric Society with Bernstein. And so this is kind of the key takeaway. PCT is a diagnostic test of choice when available. Trying to get that more available, and clinicians should use even PCARN ruler step by step. And of course, I think, well, my opinion is this is probably a much better one. Okay. Here's Gupta, and you guys may be very familiar with this in pediatrics. So this was at Children's Hospitals. This is in Toronto, also 403 febrile infants. And so this is age 30 to 90 days, and they looked at, got the outcomes were this. So admissions, antibiotics, and LPs, okay? And then again, this is 29 to 90 days. And so this is what they found, all right? So admission rates were half using the PCT algorithm with the PCARN rule, okay? Antibiotic prescriptions were reduced 91%. It's big. And then lumbar puncture, 76%. Even anytime you don't have to stick a piece of steel in somebody's back, that's like a win, right? I mean, think about it. That is definitely a win. And then the other thing was, this is integration of PCT into the decision support tool led to a reduction in admissions. Okay, so very important. So I think this is huge. Okay, and this is just kind of a note that came out. This is from Ram and Bernstein. This is what I'd like to point out. It says this: since clinicians who care for febrile young infants must have rapid access to procalcitonin results to provide best evidence, guideline adherent care, the wider availability of this test is essential to reduce unnecessary invasive testing, LPs, okay, hospitalization, antibiotic exposure, and can reduce system-wide resource utilization. Obviously, if you reduce admissions by half. I mean, if you're a parent, do you want your child in the hospital? And do you want them doing an LP? I think the answer is pretty obvious if you stop and think about it. All right, so I want to make sure I'm good on time. I'm going to talk to you guys about what I call confounders. These are situations where PCT is elevated, but it doesn't mean that you necessarily need antibiotics. And this is very important to understand. I won't hit all these because I want to leave time for questions, but I want to hit some of the key ones. This has to do with the activation of the toll receptor. So the most active places that we have bacteria, our lungs are full of bacteria, obviously our gut and the liver, okay? So most of the time when you get these elevations, it has to do with this translocation of bacteria from the original source to activate a toll receptor where these receptors don't normally see bacteria. And the other has to do with elimination. So let's deal with that one right off the bat. 1/3 of procalcitonin is excreted renally. The other 2/3 is enzymatically degraded, which means we think it's proteolytically cleaved. We're actually still not sure. So the most that we can affect PCT in somebody who's totally anephric is by 1/3. Does that make sense? But here's the important part. There's two parts. We need to look at the expected baseline, okay, and then the elimination piece. So these things change that part. So in acute renal failure, even if you have somebody in acute renal failure, they're 15 or 20 mils per minute, the baseline is not changed. So if they come in and the next day, their creatinine clearance is say 15, their PCT is 0.15, 0.12, that's normal. Okay, you don't have to treat them. Okay, but what can happen is the elimination can be slow. So instead of being 24 hours, maybe it's 26, maybe it's 28, 30, something like that. Okay. Now, this part of chronic renal failure, when I say this, I'm talking severe chronic. I mean, these patients are kind of like, do I need to do something? Do they need to be dialyzed? That's what I'm talking about. In that patient population, they have a baseline that can be 0.5 or less. I would tell you the literature sometimes says higher. I don't think they're very well done studies that publish. They publish up to 1.5. But the good rule of thumb is 0.5. Okay, and again, the elimination can be slow. So PD and hemodialysis. And so let's talk about PD. So any of your dialysis patients, if they come in, like say they're intermittent at home or they're PD at home at night or whatever the case may be, they have a PCT of 0.5 or less. That's normal. You don't have to treat them, all right, which is very important to understand. So PD patients, how do they eliminate? Well, pretty much like the normal kidneys. It depends on their peritoneal membrane, depends on their dialysate, depends on the number of dwells, the hours of dwells, but kind of the same, all right? In your dialysis patients, let's talk about intermittent, okay? In those patients, any of your dialysis patients, PCT binds the high flow, high flux membranes that we use. And so it binds very quickly. So you see it kind of go down really quickly and then it kind of plateau out. But the bottom line is if you're dialyzing with continuous renal or right after intermittent, it goes down by about 50%. Okay, so pretty close to that. Now, if they're on intermittent, so if they came from home, they're on intermittent, you're not doing them continuously. So like if you dialyze on Monday, the next day, Tuesday, it's 50%. And then if you're a day off, all right, it's almost 30% less. I mean, you can almost determine that. I mean, I have a study I can show you about that. But basically, in these patients, you can still use this. And it's important because these are critically ill patients who have a lot of infections. These are things that we need to treat. Skin and skin structure infections, I want to be clear because a lot of times this gets misleading. You can have an area of erythema, say it's like big, red, angry looking, and you look at that and you go, PCT is very low, and you go, stupid test doesn't work. What does that mean? It is extremely superficial. You can have that in those very upper levels where it hasn't become systemic. On the other hand, you can have a very small area and you can have huge levels. I had a good friend of mine who's a physician, his wife worked for me, he's a pharmacist, had a skin tag removed in the fold of his leg. PCT the next day, he had this, was 700. He spent 2 weeks in the ICU and lost both of his legs. So it's depending on how systemic that becomes, okay? Very important. Autoimmune diseases, there are only 5 that affect it. Stills, Weger's, Goodpasture's, Onca, Kawasaki's. In those patients, a level of 0.5 or less is normal. Okay, that's just to be expected, all right? And so, like right before I left practice, a Kawasaki's patient came in and her PCT was 0.43. It's normal. Okay, you don't have to do anything with that. Neutropenia, leukopenia, you can use this in your oncology patients. It's not effective. So this was the question that came up, cytokine release syndrome. Post-op severe CPR, cytokine storm, you'll elevate PCT. Normally post-op for severe trauma, 1.5 to 2 in the first 24 to 48 hours. Bacteria gets translocated. Anything that causes ischemia to the valve, absolutely, you're going to release bacteria into the peritoneal cavity, it'll elevate. Cytokine release storm. Typically, it's 1.5 to 2. There are some cases where they report it to be up to 10 to 20 in severe COVID patients. And most of these patients didn't make it, but typically it's usually 2 or less. Did I answer your question, Chris? Okay. All right. And then surgery depends on the surgery. Most of your orthopedic procedures, no. You get colon resection, yes, because, and these retroperitoneal procedures because you get bacteria that comes out. Okay. Severe pancreatitis, you'll see elevations in the 1 to 1.2 range. That's normal. A lot of people would suggest 1.8 is the cutoff as far as, i.e., if it's 1.8 or greater, you're probably going to need to do something to intervene surgically or something like that. I think the level is probably more 1.2. I think that's kind of generous, to be honest. UTIs, okay, 40% of your really old patients who you've had in the hospital over and over again are colonized, and their UA looks like they got infection, but they're not infected. 20% of those who are just older, it's the same situation. So if you get a UA, it looks like they're infected. If you have a normal PCT, they're not going to be, they're not infected. Endocarditis, low levels of PCT, 0.2 to 0.4, okay? And will you have positive blood cultures? Yes, because that infection's been hanging around so long, but it's a low level infection, typically very low. Osteomyelitis is the same thing. Usually the nodus is small, low grade infection, 0.3, 0.4, 0.2, something like that. Both of these indications, endocarditis, osteomyelitis, you cannot stop early. You can't use PCT to know when to stop. Meningitis. Any bacteria in the CNS will cause a very significant elevation of PCT. There are tons of toll receptors, and this is one of the reasons it works so well in children. I mean, you're seeing like in children with the PCARN rule, like 99.8%, 99.7% negative predictive value. Any bacteria in the CNS, you absolutely will elevate PCT significantly. Only severe burns, we remove basically you get down to just almost nothing. All the upper layers are removed, they'll be elevated. So outcomes, let me show you just a couple of these things. So if you do this, can it improve the management of your patients? I think the answer is yes, very quickly. So this was KIP. This was a study that was done in the Netherlands. The reason I include this is that the Netherlands are the second best user of antibiotics in the world. All right, they're already really good. Number one, yes, anybody want to care to guess? It's outside the US. Switzerland. Yeah, Switzerland. Okay. So this is the use of PCT algorithm. You can see that reduction in length of stay was 1.1 days in the ICU, 2.3 days in the ward. ICU reduction was just over 2,000 euros, in the ward just over 1,000. This was the use of a PCT algorithm. Okay. Now this is a couple of them. I'll address each one. So this is Denmark, the Netherlands, and the UK. What you can see is days on antibiotic therapy. That's 2.2 days. Okay, that's pretty significant. And what you see is probability of an AMR or CDI. That's a calculation that's done. Basically, you can see that the results were statistically significant, 0.0001. Okay. Hospital day was almost a day less. And in all these situations, it was about 1,000 euros less. Okay, so save the money. Now, on the other side, this is US. So days of antibiotic therapy, you can see very significant reduction. They went from 13 to just under 8. So that was almost 6-day reduction. Probability of AMR, CDI, again, 3.2 less probability and 1.7 on Clostridium difficile. Now, I want to point out this, PCT test 6.2, they went from 0 to 6.2, and PCT in the US to 5. Most of the time, you don't need that many. My goal is to have you somewhere, if you have a positive PCT, you're going to be around 3.1. Okay, you just don't need that many of them. Okay, but this is where the data was. And so days in the hospital, look at this. ICU, 3.6 days less. Days in the hospital overall, 4.3. That's big. Biggest driver of any cost in any hospital is, I think to say, I mean, it's the single biggest driver. Okay, what you also see, these are patient charges. So hospital stay, $7,700 less US, antibiotic therapy, $330, and then overall cost of patient was basically a 25% reduction. So very significant. So this is another one. This was done 3 years later, and they looked at sepsis and lower respiratory tract infections. So, and then went to the event. So what you can see is in sepsis, $7,700, lower respiratory tract, $1,600. And then this is vent. So you can see $2,100 and a little bit of savings in lower respiratory tract infections. So quite a bit of savings. So again, this is a different set. Okay. This is even a different one. What you'll see is days on antibiotic therapy. Now, this is days of therapy per 1,000 patient days. So what that means is if you had them on 2 antibiotics and you stopped them today, that counts as 2 days of therapy. Okay. So you actually go from, it's almost a half. I mean, you go from 22.8 to 10, and then PCT test 3.1, and you can see there's a very significant savings to the patient through sepsis. And then the same one, as you can see, days of therapy 5.8. Very significant reduction. And then again, cost to patient, $3,400. So very significant savings. So kind of the keys. I do want to share this with you and open it up for questions. I think we're good on time. Yeah, we got 15 minutes. That's good. Okay. So education, as you can see, is the key. If you just take this test with all these nuances and all these things, and you just throw it out there and say, okay, we got PCT available now, order it like you care to. What's going to happen? But it won't be free, okay? So you can see that there's a formalized process that needs to be in place where we educate everybody so that you know how to order it. Number 2, you know how to interpret it. Number 3, to make sure that you want to act on it, okay? So there needs to be a process in place. So usually it's part of your stewardship team, and it usually involves your clinicians, pharmacy, lab, and all those things. But just to say, okay, we're going to do this, I strongly suggest you don't do that. Okay, I just want to be clear about that. We want to make sure that you're effective. But it's been proven over again that a lack of process and lack of education will not be good. And so a lot of it has to do, as you were talking about, is that the order sets, the protocols, for instance, in your electronic health record, you don't want the electronic health record to say PCT of anything greater than 0.1 is abnormal. What you would like to do is say something in the PCT 0.25 or less, the likelihood for need of antibiotics is low, or some wording like that. PCT of 0.26 or greater, there is a need to use antibiotics. So we want that so all clinicians understand how to do that. And again, this is going to come back to that type of thing of this repetitive training over and over again. So this is kind of where you're at with PCT. Do I have a bacterial infection? Is this viral versus bacterial? What's the initial severity of illness? Are my antibiotics working? And when can I safely stop? It's not that complicated. But again, it's the process, and there needs to be some serial measurements. There needs to be that understanding. So I would open it for questions.
Yeah, I'll start. Mike, I just wanted to thank you for a great presentation. We had Mike and Peter speak to us a couple of months ago to our lab team, and I realized the presentation was so great then that this would be an excellent opportunity to help introduce this test here at RVH. We are live now. That's thanks at least in part to our pediatricians, Dr. Ho, Dr. Bartlett, and Dr. Davis, who've been advocating for this test for quite some time now. And there are some very good guidelines, both from the Canadian and American Pediatric Society, on how that test is best used in infants that are presenting with what-named sepsis to help to refine the diagnosis and to avoid invasive procedures, as Mike has alluded to. We are live with it in that application in the pediatric group. We haven't started to make this available to the rest of the hospital and to the adult patients or patients that are over at least over 3 months of age. Partly because of some of the challenges that are that accompany the interpretation of the results here. So I think Mike has outlined that in very great detail, and it's been really helpful to hear that. We want to work together with Chris and some others to help to provide some messaging that'll go out with the reportings, the test results as we release them here at RVH. And so that's kind of the next step. And this has been a really nice introduction to the sort of work that we need to do to help to implement that. So thank you. And if there's any other.
So I have a question over here.
This been used in like preservation clinics or vascular clinics where they're trying to work on chronic recovery. And then has there been any encounters with patients who are on immunosuppressants like so?
Yeah.
And then the last one, which is the one that I'm most curious about, has been used in infected grafts and following to see if the graft is infected or antibiotic therapy is still needed, because we put these patients on antibiotics. So,
Okay, so the first question, let's just do one at a time. Go ahead and you just go through and I'll answer each one.
yeah, so the first one is being used in the preservations of chronic humans with
Yeah.
ischemic legs.
Yeah, so chronic these ischemic legs limited because generally these are, you don't have a systemic PCT. So where you do see this and that's where they're progressing rapidly, where it looks like they're really progressing, is feasible, but to just do routine, the answer is probably no. The other thing is when you put them on therapy to evaluate are they working, and sometimes here's where you end up. So maybe you have somebody, maybe they're on two antibiotics, right? And so you want to stop one. Say, I'm like, okay, I feel like I want to wean them down. So here's the deal is you can stop one and then repeat a PCT in a day or two. And if it's still going down or still low, maybe stop the right one. Right? This is what you run into with like diabetic foot and things like that. Okay, so does that answer that question?
It does. I mean, I was finding it very interesting, and like, especially when you have a patient with a wound that it takes a long time to heal. Sometimes they get infected again. So I like, you know, do you every once in a while just check in with these and just to say, am I missing something?
Yes, so I'll give you personal experience. So, just within the last month, so I had a list prompt here and had dislocated lung bone and they had this major reconstruction on my left hip. And so anyway, a few months back, I had part of the bone dropped through and I put an ulcer in the bottom of my foot, right? And it was like which was 9 months to heal, right? So the question is how do you treat these people? And so you look at this, and I would look at it, and I would get off. And so 3 times of antibiotics, put back on. So PCT does help you in that initial assessment, you know, looking at them. But a lot of times, unless it's really systemic, it's going to be 0.25 or something. But still, that's much better. It's statistically relevant compared to a PCT of 1.5 or 0.1. So yes. Okay, now your second question was, yeah. So notice the answer is no, it does not affect. So people that are on corticosteroids, even if you take somebody who's done their bone marrow transplants, it doesn't really affect the PCT. We used to use one group of drugs, which is now been eliminated, that had some effect, but so the answer is kind of now, no, they're none like that. Some people, though, that are doing a bone marrow transplant oncology, what they do is they lower the cutoff. So instead of doing 0.25, they'll do 0.2 or 0.15 just to try to make it less sensitive. And on that note, is for years, we said you can never use the PCT algorithm, short duration on oncology patients, right? But now we have major oncology centers like in the US, like MD Anderson, Memorial Sloan Kettering, that are using these algorithms to shorten durations. So to answer that question, fully the answer is there's no drugs that do affect them. Okay. And the third question was
Is in patients who have grafts, so aortic grafts or bypass grafts, there's always questioning whether it's infected or not. Sometimes it's very clear. There are situations where we repair stuff with either antibiotic soaked graft or patch, and we then put patients and we try to clean up as best as possible. And then we put patients on antibiotics for the rest of their life. And has that ever been looked at?
I don't know that we have anything specifically that anecdotal evidence about that, what people are using that. but I can't give you like a study to specifically address that.
Okay.
I would use it in my patient population to look at that, but I can't give a study that's looked at it.
For patients, you said that patients can be, or patients, seniors can be colonized with bacterial infection. Can it be used for that? Like, because again, we get, I'm in microbiology, so we get so many urines down that are just cloudy urines, and it's the same thing growing all.
It's absolutely. So this is one of the reasons I brought this up. One of the biggest issues with antibiotics is urinary tract infection, particularly in Asian populations. The number is those patients who are 65 or greater who are not in a nursing home, who don't have repeated admissions to the hospital, 20%. This is the numbers. I'm just giving you numbers how high we are in that. It's estimated that 20% have a UTI. Basically, we have a biofilm built up. And anytime you get a UTI, it looks like you're infected. You're going to get 2 fructose bacteria, you're going to get some leukocyte trace, but they're not really, they don't really have infection. Now, that number in nursing home patients, particularly females, is closer to 40%. And so if one of the things that come in, particularly if you have a nursing home, somebody that's elderly, aging, and they can remove a set of strategies. So what's the first assumption? And UTI. You get the UA. I would do this. If UA looks like they're an infection, and I had a normal PCT, I would treat. And we did this all the time. It's actually one of my case studies. We had a large geriatric site on the other hospital. We treated none of those patients with, we used PCT to determine that. We had one patient one time, as actually one of my case studies, they came in and had 4+ bacteria, they had mental set changes and everything. And of course, the process of reflux culture. Reflux culture came back and it was trying to think which one. It was one of the ones that colonizes. And it was interbacterial colitis. I had to think about it for just a minute, sorry. It was interbacterial colitis. And so in this situation, it was resistant to everything but amikacin. And they said, okay, we're going to send down the antibiotics. I was like, PCT's home. So on day 5, she spiked the 10, right? So the assumption is she spiked the 10, something's got to be bacterial, right? So we repeated the PCT, it was normal, okay? And so she never got antibiotics because it was resistant to everything. I actually asked one of the nurses, why did you treat this? This is colonization. And so, this is important because what happens when amikacin doesn't work? And then the question again, I asked them, I said, why do you think you got? The term they use is, so these are all ours, but one's an S, right? When we're looking on the report, I said, how do you think you got that way? And I got the smart answer back. And you're the part B. I was like, you got this way because somebody repeatedly treated her over and over and over. And she didn't need it. Okay, so very useful in that situation. And it's a proof of that. And any other questions?
Here's using the mics and sure. Thank you.
Just for the 20% rough rule you mentioned, I don't think you discussed bacteremia. We do not apply that in a patient who's presenting with bacteremia.
Okay, so now this gets really interesting. This is okay. And this is actually one of the discussions we have with positive blood cultures and bacteremia. So I don't know if the question is, do you treat them longer, or is it short duration, or is it about PCT bacteremia culturation or beyond?
Well, just in general, like for example, would you use PCT to dictate duration? Because I'm thinking of Staph aureus bacteria.
Staph aureus, we're going to do the standards. Okay. To actually treat the infection, I think you probably could. There's been a couple of studies that looked at it, but we're not going to go against that duration in Staph aureus. Now, some of the others, we'll fight that. So here's one of the interesting things. This to me is so interesting. So in blood cultures, okay, one is estimated. We know. Okay, so basically 1 in 10 of blood cultures is positive, right? Of those, 1/3 are contaminated. Will you let people agree with that? Okay, that's just everywhere. So that means for every 100 cultures you get, you have 10 that are positive, and you have 6 that you can use. All right. So then what happens is this. Sometimes people say, well, PCT is not elevated. I've got a positive blood culture. Okay. And I said, you have the ideal situation where You put a few bacteria that multiply and double every 20 minutes to 40 minutes, 45 minutes, and you know, it's gram negative, gram positive, and you double, right? I can literally go into millions and billions of bacteria with just 10 in 2.5 hours. And so it turns positive. The question is then, well, I also do something. When I get a contaminated specimen, it's because there was enough organisms accumulated on that needle that caused a positive blood pressure. Even though I had a positive blood pressure, I didn't have enough elevated PCT because there really wasn't a pathogen. It wasn't because it grew in the broth, you know. So the answer to your question, step R's, I wouldn't change duration. To evaluate some of the others, I would. Okay, it's very useful. There is a greater likelihood that if you have negative PCT that you're never going to have a positive culture. So we had a blood culture bottle shortage in the US last year. Okay. And we use PCT to determine, okay, at least some of that go out or not, right? And then, but you can still have positive culture if you still have a low PCT. And then you can still have some that are up. You know, I had a patient who came in with PCT 110 and died an hour later. His blood cultures were positive. Like, I mean, you know, playing on, I mean, it was like in no time. So there's some correlation, but there are that sometimes a mismatch of when you get a blood culture is positive, PCT is low. That's why we find out. And here's the other questions. How many commonly forming venus is pathogenic? Nobody seems to know. Is it 10 or is it 100? You know, I mean, estimates are it's 100, but I don't know what it is take. I mean, there's a lot of, did I answer your question? Some, I didn't answer very well.
No, it's pretty good.
Yeah.
What about, abscesses?
Yeah.
It's good for abscesses too, if they're not, the localized and not systemic.
And so the abscesses will, you know, depending on how much it begins to get systemic. Things that are walled off will not. Okay. So like, for instance, I had the University of Mississippi call me, they actually sent me a CT and they said, we have this big thing on email. And it was something like 4.5 or 2.5 centimeters in the lung. And they said, PCT is that rolling home. And in our initial conversation, I said, did I have a good thick wall? And the answer was yes. Why is there a big wall? Is that what body's way to keep it from spreading? Okay. So obviously there's that surgical removal that has to take place, and that's what they decide to do. But as long as it can get out to become a little more systemic, yes, it will in an abscess. And think anything in the bowel and stuff, yeah, for sure. Thanks for that. So,
Interesting. Oh, maybe it's
One of the places is gonna be available. We're all excited in the idea.
yeah, let's fill that
I've
out.
got these customers, we could use it on trading.
Well, the short answer is that it's available today. We've kind of set the ordering priorities just to the pediatric group. Had a really good discussion with that group about patients and interpretation. And there's some very good guidelines for the patient pediatric study, so we don't support with proceeding with that. I did meet with Chris, Julio, and the cast of others from the ICU team, and I think there was a realization that to be a little bit more careful about how it's rolled out to the adult. On the one hand, obviously, as you point out, it's extremely helpful both from a diagnostic standpoint and you know, the opportunities for antibiotic stewardship are there. So they're all good things. There was a concern that seeing this go positive and thought that any positive PCT means there's a serious infection. We need to call the CCOT team. So it's about kind of wedging it somewhere between those two.
there's one thing I like to point out, particularly when you're just first starting is PCT is stable in the lab. It's almost it's refrigerated for at least 7 days or more. I don't know how long you keep your samples free.
Yeah, it's 5 days.
5 days. Okay. So here's the deal. So say, for instance, you're one of your trend, okay? As long as they had something, you know, any type of standard way to get a life, you know, a CBC, or a comp med or a basic metabolic, whatever, they can run PCT off that. So what you can do is, so if you got a PCT today, and you can actually call that, this is one of the things we did, I would say, can you give me a PCT from yesterday? Now I got a trend, okay? That's what they did in surgery patients. We never did surgery patients until we thought something's going on, right? So I get one today, and I was like, okay, give me like from yesterday, is it going up or going down, or is it the same? Now I know without wasting a lot of money, if the lab is kind enough to do that. Of course, my experience with lab food, and if you appreciate them, which I did because I managed lab, you know, that's where 90%, even 10% of the money went, 90% of the results came from versus radiology, which was the upward trend. It's like, it's like it was useful and they were one of the problems. So I think that's one time. So
useful for their classifications that has been used application population, mostly because of how it's not affected by chemotherapy treatments that are out there. So where all the other lab results come back and they're all over the place, PCT really is a constant. They have been able to really rely on. Also for the ICU, it's good that you're excited about it. But the ED really you can tell it with the, we're going to admit this patient, you know, what's my PCT on this patient? I have a PCT of 7.5, I have a PCT of 25. Those are two completely different levels. So you might think about it, this patient's 10 million for PCT.
Okay, I think if anyone has any questions, I'm sure Mike will be around for a little bit. So the thing will be up, and thanks to the lab team for being tested and this is another round of applause for our performance.